Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Dr. Brian Waterman at Wake Forest, North Carolina, who will be joining us for the entirety of the interviews. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeon Society, the University of Utah, Wake Forest, or the institutions of any of our guests. So today we're in San Diego at the 2025 annual meeting of the American Shoulder and Elbow Surgeon Society. We're conducting a series of interviews that highlight some of the great work that's been presented at the meeting. I'm continually impressed with the high quality and impact of the work at our meeting, which continues to grow bigger every year. And so it's actually very hard for us to choose which talks to highlight because there's so many great talks. The first one, I'm just delighted to be joined by my partner, Dr. Christopher Joyce. He's here at the University of Utah. He's going to talk to us about our paper, Do Wound Protectors Prevent Bacterial Colonization During Total Shoulder Arthroplasty, a Randomized Clinical Trial? Dr. Joyce, welcome to the podcast.
Thanks for having me.
We are also joined by guest host, Dr. Sara Edwards of the University of California, San Francisco, who's going to give us some insights into the implications of this work and how it fits in a larger context. Dr. Edwards, welcome to the podcast.
Thank you for having me.
All right, so Chris, tell us the background. What inspired you to do this study?
First and foremost is preventing infection in shoulder arthroplasty. Our site is one of the sites in the PJI ASES multi-center group. So that's kind of where this initially started. And then, talking with some of our colleagues that do total hip replacements, several of them at University of Utah and other places use a wound protector device, and they feel pretty strongly that it helps prevent seeding of the deep joint and soft tissue integrity through the case. So that's kind of where it started. And then we submitted this for a ASES Foundation PJI grant, and we're lucky enough to be funded for that. So that's kind of how it started.
Great. So we've got good rationale, and this is a clinical problem. We've got an interesting new innovation that we're somewhat co-opting from our lower extremity colleagues. You've got a grant from the ASES to do the study. Tell us the design of the study. Like, how did you do this study?
So we felt that the best way to do this was to randomize patients, and thankfully it's a relatively easy intervention to do, so the randomization process and not too much of a follow-up. So doing this as a randomized controlled trial was relatively straightforward. So the setup for this, we did a power analysis, found that selecting 100 patients total would be adequate, and we have 50 patients in a wound protector group and 50 patients that were controlled. And then essentially the wound protector group used the wound protector, the control group was standard, and we took tissue swabs of the deep tissue after all final implantation, and followed those for 2 weeks on aerobic and anaerobic cultures, and then looked for a number of positive cultures for each group. We also did a analysis of tissue injury at the end of the case, which we graded from a 0 to a 3 on severity, and then compared the two groups.
What did you find?
So we found, when we were looking at cultures, the difference in number of positive cultures in the wound protector group compared to the control group actually did not meet any statistical significance. If you look at the overall numbers, for total bacterial, like all bacterial species in the wound protector group, it was around 9% versus 19% in the control group. That did not meet statistical significance, as I mentioned. And then we were looking at the soft tissue injury. There was significantly less soft tissue injury in the wound protector group compared to the non-wound protector group.
So with those kind of results, are you going to use the wound protector going forward?
Yeah, it's interesting. We actually are just in the process of writing up the manuscript for this, and the science side of me, we did a power analysis, and our results showed no statistical significance. But when you look at the numbers, there is a lower rate of positive cultures in the wound protector group. Whether that met significance or not might have been more of a problem with our total population size more than anything. And then for me, the soft tissue after doing this, we graded this, as I mentioned, from 0 to 3. And basically all but one of the wound protector patients were grade 0 or 1. And almost all of the control group were grade 1 through 3 in these tissue injuries, which was basically injury to the pectoralis, the deltoid, and the cephalic vein. So for me, based on those things, whether or not that statistical significance is important, so I actually have already changed my practice, and I use a wound protector for every primary shoulder arthroplasty at this point.
Chris, walk me through the protective effects. How do you think that protects the soft tissue? Because obviously the results we were looking for, we don't find. Maybe that's a power issue, but the protection issue is a real thing for me. I mean, oftentimes with a difficult exposure, you have deltoid or cephalic vein injury. So I'm actually very interested in how you think that works.
Yeah. Initially, the first probably 10 of these I did, which was actually prior to us starting the study. It's a little futzy to use the device initially. There's a couple nuances with it. Once we got it in, it really didn't change our surgical time or difficulty from my perspective. The idea is basically once you create your initial delto-pec interval, you put in a protective sheath, and the material that this one is made out of is pretty robust, and that stays in until you're done doing anything in the deltopectoral interval. So from a muscle standpoint or a soft tissue standpoint, it really does prevent retractors from cutting into the deltoid muscle or the pectoralis muscle. The idea is that the bugs that we worry about, C. acnes, staph epi, they live in the skin and sebaceous glands. And if you can protect the skin from ever really contacting the deep wound, then in theory you're decreasing the seeding of the deep wound. And that's kind of the thought process for me.
Can you tell us a little bit about other techniques that you use to help prevent C. acnes in the wound? I kind of throw the kitchen sink at my patients, and I'm curious what else you do besides the wound protector that might be, helping.
Yeah, so for me, I guess I'm relatively early in my career, but just based on what I had done through fellowship and training, I initially was using some betadine on the wound after doing a skin incision. I actually have stopped using that, and what I'll do now, kind of from start to finish, so I use IBAN. Again, some of these things are not necessarily science-based, but I use IBAN. I use a separate DuraPrep stick prior to putting the IBAN on. There's some data in the trauma literature that supports using DuraPrep. I actually will just nick the skin, and I'll use Bovie for my skin incision all the way through, so I don't even use the knife other than just getting through that IBAN up top. Again, in theory, this is heat instead of a knife blade, might decrease the seeding of C. acnes. And then I try to keep, for my primary arthroplasties, I really try to keep my surgical time under 90 minutes. We're in a training institution, so sometimes it's a little bit difficult, but primary arthroplasties, those sets of things have worked for me. I also do use vancomycin powder. Again, it seems like that may not really have a lot of backing necessarily anymore, so I may be switching away from using that, but I still do currently use that. And at least in our institution, the three of us take this stuff very seriously, and our primary arthroplasty infection rate is very low. So that's kind of what I've been doing.
Anything on your skin prep that might be different?
Yeah, so that's a good question. We probably about maybe a year ago have switched to at least recommending to all our patients to use benzoyl peroxide prior to incision or prior to at home
with clindamycin.
Yeah, sorry, with clindamycin. Yeah. So it's an actual prescription. So the majority of patients are taking that. We at least recommend that for everybody preoperatively versus a hydrogen peroxide wash for 3 days prior. And then in the pre-op prep, based actually on Peter's work, we do a mix of an alcohol and a hydrogen peroxide wash on the skin. And then for me personally, I will initially prep with a ChloraPrep, and then I'll do a final sterile prep with DuraPrep.
I love it. I think that's great. You're throwing the kitchen sink.
It's a lot. Yeah, it's
No,
a lot.
Good.
Would you add anything, Sarah?
No, I do a very similar routine where I'll do, the benzoyl peroxide preoperatively, and then I like peroxide wash, prior to surgery, then the ChloroPrep stick, Ioband. I also use Vanc powder, although the research is maybe, and I do a betadine wash at the end, followed by saline. So betadine wash, saline, then put the Vanc powder in, then close. And so
The betadine wash is interesting. We when we had our fluid shortages, I'm not sure if you guys ran into this, but we were not allowed to use, it was like half a liter per case or something like that. So I actually started using the betadine wash for that. I've gone away from it, but I don't know. I know there's some people that like using that a lot.
the one thing I wish I could use is the acetic acid wash, which is too expensive to use on every case, at least right now, but it's been shown to have the highest kill rate against C. acne. So I do use that in revisions.
Yeah.
Bactisure is the product, but it's just vinegar, sterile vinegar. It's amazing, but it's good.
It's like Spindrift.
Yeah.
We've gotten a little bit of pushback at our institution too because the product is expensive.
It's very expensive, right?
Yeah, which is I think interesting given it's sterile vinegar.
Right. Yeah.
Chris, it seems like the best we can do is reduce bacterial burden and colonization. So what do you think is the next frontier for our war against C. acne?
I don't know. I did my training at Rothman, and there's a lot of percolation from Dr. Parvizi there, and he always preaches about basically like two things. It's host and decreasing bacterial burden. I think probably what what a lot of us have focused on, because we feel like we have more control on this, is the decrease in the bacterial burden, which honestly I think we do a pretty good job at these days, but always trying to take next steps with that. But really I think, and there's a whole session on this here this weekend, but working on the host side of things is probably more important, and I think we see that as non-modifiable risk factor type things. But, instead of saying like you can't have surgery, actually putting more time into optimizing the host is probably where more of the research should be going, I think.
Certainly that's where our lower extremity, our arthroplasty colleagues have gone for so much of their research.
Mm-hmm.
Yeah, we're looking right now at, we've had the advantage of hiring a nutritionist into our department. And so we're trying, it's been great. The patients really like it. Insurance is covering it. So it's kind of a nice thing to think about adding to your department if possible. So within a few months, she was covering her salary. It's actually pretty affordable, but our pre-op patients are seeing the nutritionist, and we're trying to get them optimized, like you're talking about, as far as albumin, vitamin D, some of these factors that have shown to be contributing to infection or outcomes, just cuff healing, subscap healing, all those things. So something to think about, maybe adding. I think we're the first department to actually have a nutritionist in the U.S. so far, employed by our orthopedic department that works with all of our patients. So it's been great. We'll see how we're collecting data. We don't know yet if we're going to really affect the outcome, but something to think about.
Yeah.
The other thing I worry about too, and you might as well, but testosterone supplementation has become very popular. Have you noticed an increase in infection in those patients or have concern? I don't know if you see that much in Utah. I imagine so. They're pretty health conscious. A lot of vitamin supplement companies in Salt Lake,
Yeah, no, I think I think that's a really good point. We actually asked that or looked into that with this study, and probably just overall, like male and female total, I think somewhere around 8% of people were on testosterone, at least within 6 months of the surgery, which is a significant amount, And again, if you look at just in the males, it's even higher than that, because that was including the females, just all comers. I have not really made too much of a change. We've actually talked about this a lot within our group, because our senior partner, Dr. Bob Tajan, feels very strongly that does contribute, and he'll actually make people stop taking testosterone, I think, for 3 months. And we've talked about potentially even studying that and seeing if there's a decrease in skin load. But there's clearly people that are on testosterone supplementation have a higher load of all bacteria, particularly C. acnes in the shoulder. A lot of that came from University of Washington. So there's probably something to it. I haven't taken any real steps towards that. I haven't changed people because actually Peter and I have talked about this too. I worry a little bit about some of the other downstream changes in hormonal effects by abruptly stopping somebody on something they've been taking. But definitely a prime time to be researching it.
Yeah, just to maybe elaborate on that side, the challenge I think is that if someone stops testosterone and they've been taking exogenous testosterone, those testosterone levels dive to zero. And then if that person is trying to heal, that's an anabolic steroid. It helps healing. So, then we're sending that person to therapy, and how are they going to grow muscle when they have no testosterone? We worry about wound healing. So, obviously the bone is also responsive to estrogen, and testosterone is converted at the tissue level by tissue aromatases into estrogen. So, I think it's a real double-edged sword, and it's a little bit unclear. It's very hard to determine the risk-benefit ratio there.
I agree. I think it's an issue. My only acute infection I've had after a total shoulder was a patient who was taking testosterone. I mean, that's just N of one, right? That's not great data, but it's just interesting that was my patient. And my partners have noted that as well. So something to think about. It'd be nice if we could all pull that data together, because I bet most of us have that story somewhere. So.
Well, look, I think it's great work, and we're really excited to see where the future will take us. I really appreciate you guys taking the time to come on with us and talk about it.
Yeah, thanks so much for having me.
Okay, we're joined today by Dr. Hussain, who's currently a shoulder fellow at Rush, drawing on his experience from residency at Emory. And he's going to be discussing his paper on bone or metal to reconstruct the proximal humerus, an analysis of functional outcomes, complications, and survival between reverse allograft prosthetic composite and endoprosthetics, or endoprosthesis. Dr. Hussain, welcome to the podcast.
Thank you so much for having me. I'm delighted to be here.
Joining us also as a guest host is Dr. Srikumaran of Hopkins. Welcome to the podcast.
Thank you. Happy to be here.
All right. So Zaamin, tell us what inspired the study.
Yeah, so firstly, I just want to give a shout out to the whole team at Emory, particularly Eric Wagner, who's a phenomenal mentor of mine, and we've had a lot of fun thinking about this. I think more surgeons are putting in shoulder arthroplasties than ever before, and revision surgery is becoming more and more common. And Uma, you've taught us a lot about how this trend is going to increase at least until 2030. And with that, proximal humeral bone loss is becoming more problematic too. Main indications for this being tumor, failed arthroplasty for loosening, infection, and previous trauma. And classifications to quantify the severity of bone loss have been helpful, including yours, Peter, that was beautifully validated. And really, there's been two main ways to recreate proximal humeral bony architecture. That's the Allograft prosthetic composite, APC, with a reverse arthroplasty embedded into it, and Endoprosthesis, which typically is in a hemi or a reverse configuration, which has a large metal proximal body. And the advantages of metal clearly are kind of reduced OR time. It's technically easier, but it's limited in which the soft tissues are more challenging to attach to it, and it has a higher instability and a loosening risk associated with it. APCs offer the potential for healing at the graft-host junction and offer the option of more soft tissue attachments directly into the allograft. So, as we know, these surgeries are fraught with complications, and a recent meta-analysis showed that 15 to 20% of both APCs and reverse endoprostheses have that high of a complication rate, and it's really unclear which is currently better. And that's mainly unclear because the indications for these are so heterogeneous, the pathology and the severity of the pathology is so heterogeneous, the techniques to perform these surgeries are all very different, and there's many confounding variables too, including bone loss severity and the number of prior procedures a lot of these patients have had as well. And throughout the literature, most of these studies are in such small samples, and there's really no modern direct comparisons between these in a single series. So the purpose of this study was to directly compare outcomes, complications, and survival between reverse APC, reverse endoprosthesis, and hemiarthroplasty endoprosthesis. And we hypothesized that reverse APC would be associated with a higher complication-free survival and a lower rate of dislocation.
Well, that's a great preamble to this somewhat complex topic, and I'd love to pick up with indications later, but maybe you can start by just telling us about your study and your key findings.
Yeah, so this was a retrospective single institution study, 3 surgeons over a decade in 2013 to 2023. Admittedly, we found that most of the endoprostheses were done for tumor indications, and most of the APCs were done mainly for failed arthroplasty. And we really looked at the complication rates, survival, and also the outcomes. Overall, we found that the APCs had the lowest complication rate at around 25%, and this was followed by a reverse endoprosthesis at 50%, and the hemi-endoprosthesis had an overall complication of 90%. In terms of dislocation, we found that half of the hemis dislocated, and a quarter of the reverse endoprostheses dislocated, but none of the APCs dislocated. And then also loosening, we found that there was about a 14% rate of loosening in the reverse endoprosthesis, but none of the other prostheses loosened. So we found overall similar patient-reported outcome measures. One interesting thing we found was that the risk of loosening actually was much higher, and the risk of dislocation was much higher once you start to approach that 8 to 10 centimeters of bone loss, which I think is fascinating. I think other things that other similar studies have looked at are incorporation of the grafts at the graft-host junction, and we found about 2/3 of our APCs incorporated.
So it sounds like while the outcomes may be similar, these two different approaches do have different risk profiles. I mean, would you say that's true in terms of like what's going to happen to the patient going forward?
Yeah, exactly, Peter. I think that's what we found, that the endoprosthesis in our cohort at least seem to have a higher dislocation rate and a higher loosening rate. And the APCs, there are a couple of cases of failure because of graft incorporation, and also there was a fracture of the allograft in one case. So I think the complication profile is different, and it's really this is, as you know, is a single series, and this is mainly just what we found.
Well, certainly this is somewhat of a pick your poison then kind of solution. Well, like, what is your go-to solution when it comes to that kind of Pharos 2B, Pharos 3 bone loss where you get into that 8 to 10 centimeter range in your practice currently?
Yeah, it's a good question. I think definitely I lean heavily towards the APC for various reasons. There aren't a lot of what I would say high quality options for the fully endoprosthetic all metal that allow you to deal with the soft tissues. I think that's an important point to consider. A lot of our technologies, heavily bone-based evaluations for CT scans and x-rays, but I think when you get in there, there's a lot of soft tissue issues. The plasticity of the tissue, the compliance, the tensioning, both proximally around the rotator cuff. So if you're considering reverse, it's very important for instability. And it was one of the surprising findings for me from the studies was I've certainly had instability related to APC-related reverses, and even intra-op have struggled to obtain time zero stability. So we've converted some to hemi-APCs initially and sometimes later. But I like the flexibility of having the allograft to be able to size it accordingly, and the allograft with the soft tissues. Attachments is helpful to deal with some of these soft tissue tensioning issues, and some of the patients just don't have a lot of good remaining soft tissue envelope around whatever you're putting in, whether it's metal or the allograft bone. So having an option with the soft tissues to secure into some native remnant cuff or tendons, performing the tendon transfers with the APC, I think those are some advantages that I prefer.
It sounds like some of the challenges, were around incorporation of the graft, and I've certainly think that's been the traditional criticism, I would say, of APCs is how do we expect with a large bulk allograft that it's all going to incorporate and heal, or is it going to fracture later, or is it maybe never going to heal? Are there lessons learned in the series as you looked through all the cases Eric had done about how to improve graft incorporation rates?
Yes, there are a few technical things that we do to try and reduce the risk of graft kind of healing issues. These patients have poor healing potential, and a lot of them have had previous surgery before, and we have tried to combine a few key technical aspects from some of the other surrounding literature. Joaquin Sanchez Sotelo uses plates on his to bridge the allograft host junction. So we've incorporated that, and Mark Frankel and Pascal Below have used step cuts in their junction, and we've also incorporated that. We've Pascal Below series in 2020, used Lepiscobo transfers, and while we didn't do that transfer, we used a lot of other tendon transfers, and while that also helps with stability, the hope is that also brings with it some vascularity to the area, and perhaps improves the healing rate as well. So there are some things, and I think it's still a work in progress. As the early cases are probably things are techniques, and we're always learning. So I think the cases we're doing now are probably even better than ones we've done earlier.
Uma, what's your critical threshold above which, bone loss wise, you will go to an APC? Can you define that threshold for us, and then maybe explain your technique for how you encourage incorporation, whether it's a telescoping method, a step cut, plate-based system, cerclage?
Sure. So in terms of bone loss, I've tried some with just minimal bone loss of the tuberosities, and those are, I think, difficult to manage. So I think you need a little bit more bone loss than that to go to an APC. So probably subcalcar, calcar and subcalcar is a good place to start for an APC. Getting it sized appropriately is a good technical thing if you can with your allograft source supply. If you can match something to the patient size, it's helpful. In terms of our technique, things that have helped, and as Dr. Hussain mentioned, the advances by Dr. Frankel and Dr. Sanchez Sotelo, I think the next evolutionary step is the implants that allow you to interlock. So the distal aspect of your implant is essentially a nail. So you can get that into your native distal humeral bone. And I don't do step cuts. The advantage of that being you can now play with your retroversion freely and trial things. And I think that's very important with these APCs. Again, getting back to the soft tissues, you really want to feel the soft tissue tension. It varies quite a bit. Even in the paper, we saw a heavy amount of these cases were tumor related, but a primary surgery. It's quite different than a third or fourth revision reverse arthroplasty where the tissues just behave differently. So I think having that soft tissue attachments to the allograft, using a telescoping technique with your broach to size it instead of preoperatively kind of measuring from the contralateral arm, that humeral link may just no longer be relevant after the third or fourth surgery, especially in infections and things like that. So telescoping your broach to kind of up to the glenosphere that you've already placed to give you a good gross size of your graft, and then you can make some micro adjustments. And with a clean transverse cut, you can set your retroversion intra-op, and then you can interlock distally, proximally and distally. That helps a lot simplifying the procedure. So you're no longer using step cuts or cement or plates and trying to fire screws and miss your implant. So I think that's been helpful. And then the tendon transfers after that to enhance your soft tissue stability.
I love all those tips and tricks. I mean, one of the challenges I think with the APC, and part of what I think actually has driven the market more towards endoprosthesis, is the complexity of the operation. Can I ask one maybe technical question here? The traditional APC, like the Pascal Below APC, the stem goes, and this is the same way you're describing, the stem goes through the allograft into native humerus. So the stem acts like kind of like a nail aligning them. There's another style of APC that's been more popularized by the Mayo Clinic where the stem is solely within the allograft. And the benefit then, of course, is you can reduce the allograft prosthetic composite to the glenosphere and then reduce that to the native humerus, and then you can put it in a lot of compression. So instead of reducing the glenohumeral joint, you're reducing basically humerus as you reduce it. Then obviously some compression theoretically could be good for healing, but then you don't you have to use a plate because you don't have any stem crossing it. Were these APCs that kind of Mayo style construct, or are they the original kind of, Franco-Boileau style construct?
It's a combination of both. So we use a stem that bypasses the junction all the way down. It doesn't take interlocks, it doesn't use interlocks, but the stem goes all the way through distally, and a plate bridges it, and then the joint is reduced. So it's a combination of both. The idea is that, and we also cement the stem distally in the native bone as well. So the idea in these patients who have limited healing potential is that although healing is ideal, and we would prefer these patients to heal, some of them may not. So in some ways, it's better in our mind to make it a really stiff construct that it can kind of try and avoid failure. And let's say even if the patient doesn't have great healing potential, we try and still have a good construct that will be functional for the patient, ideally in the long term.
And one of the things that you identify in your paper too is the deltoid insertion involvement was a predictor of complications. And I'm wondering, how has this changed the practice at Emory or otherwise moving forward? Is there something we should be doing to better bolster healing? Or is that just a proxy for the level of bony involvement?
Yeah, so we found that I think with smaller defects, less than 8 to 10 centimeters, before the deltoid gets involved, that I think reversers and APCs are both reasonable options as long as the patients are counseled that the complication risk is high. But once you start getting beyond that and the deltoid is involved, you lose your deltoid tension. I think the risk of loosening instability becomes much, much higher. And I think in this group, we probably, at least based on our series, we'd recommend doing APC with tendon transfers to avoid that risk of instability and loosening.
Well, it sounds like we still have a lot to learn about all of them, and both APCs and Endoprosthesis, and I think it's really exciting work. It's somewhat, I think, heartening to hear that maybe the outcomes are similar while the problems are different. So I congratulate you and Eric on this work, and I appreciate you coming to take the time to talk to us about it, and I appreciate you as well taking the time to share your thoughts. I think those will all be valuable to listeners as they think about how to address, this kind of severe humeral bone loss cases.
Yeah, fantastic work.
Thanks for having me.
Congratulations to you and Peter, obviously, and Brian. Incredible content that just can't be missed. I personally, training recently, learned a ton from you guys and your guests, and now that you've run over 100 podcasts, to have the perseverance to keep on going, I think is just a testament to your dedication to the ASES, so well done.
Well, we're happy to have you, it sounds like, as a longtime listener now as a guest. We're joined now with Dr. Dane Salazar of Loyola, who's going to discuss his paper, Standard versus Retentive Polyethylene Liners in Reverse Total Shoulder Arthroplasty, an Intercompany Product Comparison. Dr. Salazar, welcome to the podcast.
Good morning. Thanks for having me.
Joining us as guest host is Dr. Friedman, who's now the Vice Chair of Research at the Medical University of South Carolina. Dr. Friedman, welcome to the podcast.
Thank you very much for having me.
So, Dane, tell us what inspired you to do this study.
Yeah, I think what inspired this was a clinical question. As I do more reverse shoulder arthroplasty and work at a tertiary referral center, I'm often exposed to implant systems that I'm not as intimately familiar with, especially in revision surgery. So for me, it became very apparent and very important that I had to understand the nuance and the modularity that each of those systems brought to the table so that I could change intraoperative variables to affect the best outcome for the patient. And what I discovered was that there was a lot of variability in nomenclature, especially when it came to polyethylene bearing surfaces between and in other company systems.
So then what did you actually do in the study?
So what we did is we took the bearing surface that were commercially available in the United States, and we tried to establish what the capture ratio is for each one of those. So the capture ratio, as described, is basically the liner depth divided by the glenosphere radius. And what that should give you is the percent coverage of the bearing surface onto the glenosphere. It's a static number, And obviously we understand that range of motion and biomechanics are dynamic, but it's been well established and well vetted. And it's something that mathematically we can compare apples to apples. So we calculated that for the available implant systems that we use in the United States.
So, and it's a dimensionless number, right? It's millimeters divided by millimeters.
Correct. It's a percent.
So even across companies that maybe have wide range in glenosphere sizes, you can still calculate for each of their combinations, this would be the capture ratio.
That's correct.
And then what did you find?
Well, we found that there was a statistically significant amount of variability between companies and within companies. And so what we found is that for companies that use the nomenclature of a standard bearing, that there was variability. So at the low end, you had 40% capture ratio in the Medacta system, and at the high end of the standard was the Stryker Reunion, which is 62%. So the mean was about 49% capture ratio, and the standard deviation was about 5% or so. So that most of the companies fell between one standard deviation from the mean. But when we talked about standard liners, 7 company systems were above one standard deviation from the mean, and 4 fell below that, and that was statistically significant.
And then, so that's on the standard ratio. What about for the more kind of constrained retentive?
So, as we know, constraint can really come in 2 different ways. One would be giving you a deeper dish, and the second would be building up a medial liner. And some systems do it one way, some do it the other, and some do both, right? There are some systems where you can get a deeper dish and a medial lip, or one or the other. And what we found is with the retentive nomenclature, on average, it was about 62% for the capture ratio, but that ranged anywhere from 47 to 71. So what you'll notice in those numbers is there's great overlap in those numbers between standard and retentive. So what might be defined as the standard liner in one company's system, according to capture ratio, is the retentive liner in another company's system. So we have to be very careful as surgeons understanding the biomechanics of the variables that we're changing, especially for tensioning and reverse. So with the retentive liners, we found that 7 companies were below one standard deviation from the mean, and 4 companies were above. As an example, in one company, Zimmer Biomet, the retentive liner for the trabecular metal system was 47% capture ratio, but for the same company in the identity and the comprehensive, the retentive liner was 71% capture ratio, which is widely variable for the same company.
So loaded question here.
Yeah.
Do you think there's a role for standardization of this nomenclature?
Absolutely, and I think that was the impetus, because I think what we need is transparency. As scientists and surgeons, we have to understand the products we're utilizing and the variables that we can change, and how we change those is very important. So I think getting away from using terms like standard and retentive, because this study shows that those really don't mean much and they don't describe to the surgeon exactly what's happened biomechanically, we should move to terms that are more reproducible and that we can understand apples to apples comparisons. And I think that the constraint ratio, although not perfect because it simplifies a very dynamic process into a static mathematic measurement, and it may not capture all the nuances, it's a good starting point that we can compare all of the different bearing surfaces and at least talk in the same terminology.
And Dr. Friedman, I know you've been around reverse for a long time. You've been on design teams. You know a ton about these implants. When you hear all of this, do you think that we should stick with these terms? Do you think that surgeons should move towards what Dane is suggesting, where the implant just tells you how constrained it is? Are we really describing the whole thing with this, or should surgeons know more on the depth and the radius of curvature side?
So that's a pretty loaded question, and I would say yes to all, but let me break it down. So I agree with Dane 100%. We don't have any type of standardization, and I think it's really important that we do. You need to start with the terminology. He uses the term retentive, I use the term constrained. So again, we need to use the same terminology to make sure we're discussing and understand each other. But I think that information is very, very important. Surgeons need to understand the system that they're using, particularly when you're in a situation with revisions and using systems that you may not be totally familiar with. You need to understand the mechanics, the biomechanics, the dimensions and all, because you want to optimize the outcome as best as you can for your patient. You need to understand the system that you're using in order to do that. So it's really important that I think we need to try and push industry to standardize things, to have similar nomenclature, and make it fairly transparent and obvious so the surgeon knows exactly what he's getting into, what he's dealing with, and can plan preoperatively what he needs to do to accomplish the best outcome for their patients.
So I guess the next question then, Dane, is when you publish this, will you publish it with recommendations for industry to say, when you label your implants, they should be labeled like this?
Yeah, it's a good question. I think that's probably a little bit outside of the scope of the project. I think what we're trying to do here is identify a problem that we think needs a thoughtful answer. And so our conclusion is that there needs to be more standardization and more transparency, but I'm not sure I have the solution or the right answer to both of those things. But it's clear and obvious to me that the best thing for our patients is that surgeons are armed with the appropriate knowledge and can easily get to those numbers and calculations with the implant system of their choice.
Maybe a role for the ASES.
I agree.
And we're at ASES annual meeting 2025. Is there a threshold above which you want to establish here today? Dane Salazar, private citizen. This constraint ratio is above this, should be considered retentive or congruent.
I don't think we have that data, and I want to be thoughtful in my answer. There are certainly, I think when you get one or two standard deviations from the mean, you have to be very understanding of what you're doing. So I don't think it's wrong to say, I'm going to put in a liner that has a 0.75 constraint ratio. There may be a clinical role for that. But if that is your standard everyday liner and that isn't in line with what other surgeons are doing, you have to ask yourself why. So I don't know that we've established the threshold, but certainly I think this data gives us very strong indications around which the means for the less constrained and more constrained liners are. But I think that's a very interesting point that you bring up. Is there too shallow? Is there too deep? Because you're always robbing Peter to pay Paul. Every time you make one of these design decisions from an engineering standpoint, you have clinical implications, and you need to understand that there are implications that you understand and ones that you might not have intended. And so you have to be very thoughtful and careful.
Dr. Friedman, what are your indications for using a constrained or retentive liner currently in your practice?
So, there's been some thought in the past that the more constrained or retentive liners will affect motion. There have been a couple of studies recently that have shown that has not been the case practically. There are many factors that affect range of motion, so maybe having a few millimeters of lip liner may or may not have that happen. So for me, I reserve the constrained liners, and again, what is a constrained liner? To Dane's point, one system's constrained liner or one system's normal liner may be someone else's constrained liner. So if I've got a really difficult patient, I'm going back for like the third time revision for instability, I may want one that's got a really deep dish, that's got a really raised lip to increase the jumping distance to try and minimize any further instability. And again, it's hard to get that information now based on what the companies supply. So if we all have that information available, that helps with my preoperative planning. But I tend to save the retentive or the constrained liners for the more difficult second and third time revision instability cases.
There's constraint, but there's all and range of motion, but there's also concerns about notching. Has it been, the clinical experience, or do you guys, when you read the literature, do you feel like there's an association between constrained liners and notching in the future, or do you feel like the literature in your experience does not bear that out either?
Well, I think you can't talk to that in a vacuum, right? Because the neck shaft angle of the humerus on the stem or stemless implant is very, very important in that. And we know that a more valgus humeral implant system is going to have higher rates of notching, and that's likely due to adduction impingement because you have more distalization, less lateralization. So I think all of those things have to be taken into account, but they're all very, very important. And for me, I take the soft tissue balancing into account when I'm thinking about how much constraint or retention I need. For instance, If someone has a subscapularis deficient shoulder and I'm using a 135 neck shaft angle implant, I may more consider using a lipped medial liner to give me more constraint there because I'm worried about instability from the subscapularis insufficiency. So I think it's a complex interplay of having a personal algorithm to balancing both your anatomic and your reverse shoulder arthroplasties, but you have to understand what each one of those variables does.
This is part of what makes reverse so interesting right now, right? Is there's variability on the bony and the soft tissue side the patient presents us with, and then we have so many options on the implant side, not only in the geometry of the implants, but also in the place in which you place them.
It's not just all that, but it's also technique, right? So for example, I can take the glenoid base plate and tilt it more inferior, and so that will hopefully lessen the risk of scapular notching. So if I'm using a deeper dish liner or one that's deep dish and medially built up, I might tend to put the base plate in the glenosphere in more inferior tilt to help minimize that happening. So it's not just the bone and not just the implants, but it's also where you put them in space.
So it may be difficult for us to understand this one factor and how does it fit in, because there's also some other factors that are also, contributors to this problem.
Yeah, I mean, I think the take-home message is that each one of these is important, and we need to be thoughtful in thinking about these and continuing to fine-tune what we can do technically to impact the outcomes for our patients.
And I think that you, in your paper and in your presentation, will convey two main take-home messages, right? Neck shaft angle and transparency around constraint.
That's
as
exactly
a
right.
codifiable factor.
Well, look, this is great work and a fascinating discussion as always about reverse biomechanics. So I congratulate you guys for the work you've done here, and I'm excited to see, the directions you and hopefully the ASES will take with it going forward. So thanks for taking the time.
You're welcome. My pleasure.
Thanks for having us.